If you wake up in the middle of the night with tingling, numbness, or pins and needles in your hands, do not brush it off as just sleeping in a funny position. Because while occasional hand tingling from a compressed arm during sleep is harmless, persistent, or recurring, nighttime hand tingling is one of the earliest warning signs of a condition that, left untreated, can lead to permanent nerve damage, loss of hand function, muscle wasting, and chronic pain that never fully goes away. And after the age of 50, the risk of this condition skyrockets in ways that most people do not anticipate. I am going to explain exactly what is happening inside your wrist and hand when you experience nighttime tingling, why the symptoms are often worse at night, what conditions cause this pattern, and most importantly, what you need to do right now to prevent irreversible nerve damage. The most common cause of nighttime hand tingling in adults over 50 is carpal tunnel syndrome. And before you stop listening because you think carpal tunnel is just a repetitive strain injury that affects office workers and typists, let me tell you why that belief is dangerously wrong. Carpal tunnel syndrome is not primarily a repetitive strain injury. It is a compression neuropathy, a condition where a nerve is physically squeezed, pinched, and slowly strangled inside a rigid anatomical tunnel, and the factors that cause this compression become dramatically more prevalent after the age of 50, regardless of your occupation or computer use. Let me describe the anatomy so you understand exactly what is happening. Your carpal tunnel is a narrow passageway on the palm side of your wrist, about the size of your thumb in diameter. The floor and walls of this tunnel are formed by the small carpal bones of your wrist. The roof is formed by a thick band of connective tissue called the transverse carpal ligament. Running through this tunnel are 9 flexor tendons that control the bending of your fingers and one critically important nerve, the median nerve. The median nerve provides sensation to your thumb, index finger, middle finger, and the thumb side of your ring finger. It also controls several small muscles at the base of your thumb that are essential for grip strength and fine motor function. The problem is simple but devastating. The carpal tunnel is rigid, it cannot expand, and the median nerve is the most vulnerable structure inside it. When anything causes the contents of the tunnel to swell, even slightly, the nerve gets compressed. And as you age, multiple factors conspire to create exactly this kind of swelling and compression. First, hormonal changes. In women, the decline in estrogen that occurs during and after menopause leads to changes in fluid retention and tissue swelling that directly affect the carpal tunnel. This is why carpal tunnel syndrome is significantly more common in women than men, and why it often first appears during the menopausal transition. Second, metabolic conditions. Diabetes, hypothyroidism, rheumatoid arthritis, and obesity all increase the risk of carpal tunnel syndrome, and the prevalence of every one of these conditions increases with age. Diabetes causes nerve damage and tissue changes that make the median nerve more vulnerable to compression. Hypothyroidism causes fluid retention and tissue swelling. Rheumatoid arthritis causes inflammation of the tendon sheaths inside the tunnel. Obesity increases fat deposits and fluid retention throughout the body, including in the wrist. Third, age-related changes in the tendons and ligaments themselves. The flexor tendons that run through the carpal tunnel develop thickening and degenerative changes with age. The synovial tissue that lubricates these tendons can become inflamed and swollen, a condition called tenosynovitis, and the transverse carpal ligament can thicken and become less flexible, further reducing the available space inside the tunnel. Now, here is why the symptoms are characteristically worse at night. When you sleep, most people naturally flex their wrists, curling their hands inward or tucking them under a pillow. Wrist flexion dramatically narrows the carpal tunnel. Research using MRI has shown that flexing the wrist to 90 degrees reduces the cross-sectional area of the carpal tunnel by approximately 20%. If the tunnel is already crowded due to tendon swelling, fluid retention, or tissue thickening, this additional narrowing can be enough to compress the median nerve significantly. Additionally, when you are lying down, the redistribution of body fluid toward the upper extremities increases swelling in the wrists. During the day, Gravity keeps much of your fluid in your lower body. At night, that fluid redistributes more evenly, and the resulting increase in tissue fluid around the carpal tunnel adds to the compression. This is why people with carpal tunnel syndrome typically report that their symptoms are worst in the early morning hours. The fluid has had all night to accumulate. The earliest symptoms are tingling, numbness, or a pins and needles sensation in the thumb, index finger, middle finger, and thumb side of the ring finger. Notably, the little finger is not affected by carpal tunnel syndrome. It is innervated by a different nerve, the ulnar nerve. If your little finger is tingling, the problem is likely something else, possibly cubital tunnel syndrome, which involves compression of the ulnar nerve at the elbow. Many people in the early stages describe waking up in the night and shaking their hand vigorously to restore sensation, a behavior so characteristic that doctors call it the flick sign. If you find yourself frequently shaking out your hand at night or first thing in the morning to relieve numbness and tingling, that is a strong diagnostic clue for carpal tunnel syndrome. As the condition progresses without treatment, the symptoms begin appearing during the day as well, particularly during activities that involve wrist flexion or sustained gripping, like driving, holding a phone, reading a book, or gripping a steering wheel. People start dropping objects because their grip weakens. Fine motor tasks like buttoning a shirt, threading a needle, or picking up small objects become difficult. And in advanced cases, the muscles at the base of the thumb, collectively called the thenar eminence, begin to visibly waste away, creating a flattened or sunken appearance at the base of the thumb. This muscle wasting represents permanent nerve damage and permanent loss of function that cannot be fully recovered even with surgery. This is why I am so urgent about this message. Carpal tunnel syndrome is almost always fully treatable if caught early. But if you ignore the nighttime tingling for months or years, allowing the nerve to sustain chronic compression and progressive damage, the window for full recovery closes. Nerves can regenerate to some extent, but there is a point of no return beyond which the damage to the nerve fibers is permanent. The goal is to intervene before that point is reached. So what should you do? First, see your doctor and request a nerve conduction study, also called an electromyography or EMG test. This test measures the speed at which electrical signals travel through your median nerve. Slowed conduction velocity across the carpal tunnel confirms the diagnosis and quantifies the severity of nerve compression. This information is essential for guiding treatment decisions. For mild to moderate carpal tunnel syndrome, conservative treatment is often highly effective. The single most important intervention is wearing a wrist splint at night. A nighttime splint holds your wrist in a neutral position, not flexed, not extended, which maximizes the space inside the carpal tunnel and prevents the nerve compression that occurs with wrist flexion during sleep. Studies have shown that consistent nighttime splinting for 4 to 6 weeks significantly reduces symptoms in the majority of patients with mild to moderate carpal tunnel syndrome. Beyond splinting, there are several additional conservative measures that help. Corticosteroid injection into the carpal tunnel can reduce inflammation and swelling, providing relief that lasts weeks to months and sometimes permanently in mild cases. Physical therapy exercises that focus on nerve gliding, gently moving the median nerve through its full range of motion within the carpal tunnel, can reduce adhesions and improve nerve mobility. Managing underlying conditions like diabetes, hypothyroidism, and rheumatoid arthritis can address the root causes of increased pressure in the tunnel. For severe carpal tunnel syndrome, where there is significant muscle wasting, constant numbness, or marked slowing on nerve conduction studies, surgery is usually recommended. The surgery, called carpal tunnel release, involves cutting the transverse carpal ligament to permanently enlarge the tunnel and relieve pressure on the nerve. It is one of the most commonly performed surgeries in the world. It can be done under local anesthesia as an outpatient procedure, and the success rate is excellent. Over 90% of patients experience significant symptom relief. Recovery typically takes a few weeks to a few months for full hand strength to return. But I want to emphasize something critical. Even after successful surgery, Nerve damage that occurred before the operation may not fully reverse. This is why early intervention is so important. The best outcome happens when treatment begins at the stage of intermittent nighttime tingling, before daytime symptoms, grip weakness, or muscle wasting develop. I also want to mention other conditions that can cause nighttime hand tingling, because carpal tunnel syndrome is the most common but not the only possibility. Cervical radiculopathy, compression of a nerve root in the neck, can cause arm and hand tingling that may be worse at night. Peripheral neuropathy from diabetes or other causes can affect the hands, although it more commonly starts in the feet. Thoracic outlet syndrome, where nerves are compressed between the collarbone and first rib, can cause arm and hand symptoms that worsen with certain sleeping positions. And vitamin B12 deficiency, which is increasingly common in older adults due to decreased stomach acid production and certain medications, can cause tingling in the hands and feet. This is why a proper medical evaluation is important, rather than simply assuming the cause. The nerve conduction study, combined with a physical examination and potentially imaging of the cervical spine, can distinguish between these different causes and ensure you receive the right treatment for the right problem. Let me give you some practical tips for reducing nighttime hand tingling starting tonight. Avoid sleeping with your wrists flexed. Try to keep your hands and wrists in a relaxed, neutral position. A simple over-the-counter wrist brace from any pharmacy can hold your wrists straight while you sleep. Avoid sleeping with your arms above your head or tucked under your pillow, as these positions can increase nerve compression. If you experience tingling, try gently extending your wrist and fingers and holding the stretch for 30 seconds. This opens the carpal tunnel and can provide immediate relief. Reduce daytime activities that involve prolonged wrist flexion or repetitive gripping, or take frequent breaks to stretch and rest your wrists. If you drink alcohol, be aware that alcohol increases fluid retention and tissue swelling, which can worsen carpal tunnel symptoms. If you are carrying excess weight, even modest weight loss can reduce pressure on the carpal tunnel and improve symptoms. And if you are taking any medications that cause fluid retention, including some blood pressure medications, hormonal therapies, and anti-inflammatory drugs, discuss with your doctor whether alternatives are available. The bottom line is this: nighttime hand tingling is not a normal part of aging. It is your body sending an alarm signal that a nerve is being compressed and damaged. If you act early, the condition is almost always completely reversible with simple, conservative measures. If you wait too long, you risk permanent nerve damage, permanent loss of hand function, and permanent pain. The stakes could not be higher for your independence and quality of life. Please share this video with anyone over 50 who has mentioned waking up with numb or tingling hands. You might be the person who saves their hand function. Subscribe to this channel for critical health information you will not hear anywhere else, and leave a comment below if you have experienced nighttime hand tingling. I want to hear your story. I want to share a statistic that puts the urgency of this message in perspective. Approximately 10% of the general population will develop carpal tunnel syndrome at some point in their lives. Among women over 50, the prevalence is even higher. Some studies estimate 15 to 20%. Among people with diabetes, the prevalence is roughly 2 to 3 times higher than the general population. Among people with hypothyroidism, similarly elevated. If you are a woman over 50 with diabetes or thyroid disease, your risk of developing carpal tunnel syndrome is substantial, and being vigilant about nighttime hand tingling is not paranoia. It is prudent medical awareness. There is an important self-test you can do right now, at home, without any special equipment, to check for carpal tunnel syndrome. It is called Phelan's test. Hold both hands in front of you and press the backs of your hands together so that your wrists are fully flexed, your fingers pointing downward. Hold this position for 60 seconds. If you develop tingling, numbness, or pins and needles in your thumb, index finger, or middle finger during this test, it is strongly suggestive of carpal tunnel syndrome. Another test is called Tingel's sign. Tap lightly on the palm side of your wrist, right over the carpal tunnel, with 2 fingers. If this tapping reproduces tingling in your fingers, It is another positive indicator. These home tests are not definitive diagnoses. A nerve conduction study is needed for confirmation, but they can tell you whether you need to see your doctor sooner rather than later. Let me discuss the relationship between carpal tunnel syndrome and other common medications that seniors take. Aromatase inhibitors, which are used to treat breast cancer, have been associated with significantly increased rates of carpal tunnel syndrome. Some studies report rates as high as 20 to 30% in women taking these medications. If you are on an aromatase inhibitor and developing hand tingling, tell your oncologist immediately. Similarly, some blood pressure medications cause fluid retention that can exacerbate carpal tunnel symptoms. Even something as common as over-the-counter ibuprofen, while reducing inflammation elsewhere in the body, does not effectively reduce swelling inside the carpal tunnel because of the tunnel's rigid anatomy. Ergonomics deserves a thorough discussion because many people develop or worsen carpal tunnel syndrome through daily activities they could easily modify. When using a computer, your keyboard should be at elbow height, and your wrists should remain in a neutral position, not bent upward, not bent downward, not angled to either side. Wrist rests are useful only during typing pauses, not during active typing, because resting your wrists while typing actually increases the pressure in the carpal tunnel. When using a smartphone, avoid prolonged gripping and repetitive thumb scrolling, which load the tendons in the carpal tunnel. When driving, take breaks on long trips to stretch your hands and wrists. The sustained grip on the steering wheel combined with vibration from the road creates a particularly stressful environment for the median nerve. I want to explain what happens at the microscopic level when the median nerve is chronically compressed, because understanding this helps people appreciate why early treatment matters so much. A nerve is not a single wire. It is a bundle of thousands of individual nerve fibers, each wrapped in its own insulating sheath of myelin. When the nerve is compressed, the first thing that happens is a reduction in blood flow to the nerve itself. Nerves have their own tiny blood vessels called vasa nervorum that provide oxygen and nutrients. As blood flow drops, the nerve fibers begin to malfunction. They fire erratically, producing tingling and numbness. This is the early, reversible stage. If the compression continues, the myelin sheaths begin to break down, a process called demyelination. Demyelinated nerve fibers conduct signals slowly and unreliably, which is exactly what the nerve conduction study detects. This stage is still largely reversible if the compression is relieved, but if the compression persists beyond this point, the nerve fibers themselves, the axons, begin to die. Axonal degeneration is much harder to reverse. New axons can regenerate, but they grow at a rate of only about 1 millimeter per day, roughly 1 inch per month. And the regenerated nerve fibers may not reconnect as precisely as the originals, which is why recovery from advanced carpal tunnel syndrome is often incomplete. The muscles that have lost their nerve supply begin to waste away, and once significant muscle atrophy has occurred, it may never fully recover even after successful surgical decompression. Let me address bilateral carpal tunnel syndrome, when both hands are affected, which is actually quite common. Studies show that approximately 50 to 60% of people with carpal tunnel syndrome in one hand will eventually develop it in the other hand as well. The underlying risk factors, age, hormonal changes, metabolic conditions, affect both wrists equally. If you are experiencing symptoms in one hand, it is wise to take preventive measures for both hands, including nighttime splinting of both wrists and attention to bilateral ergonomic improvements. For anyone who has been told they need carpal tunnel surgery and is hesitant, let me address some common concerns. The surgery takes approximately 15 to 20 minutes. It can be performed under local anesthesia. You are awake the entire time. Most patients go home the same day. The incision is small, usually about 2 inches on the palm. You can typically use your hand for light activities within days, and most people return to full function within 6 to 12 weeks. The risk of complications is low, less than 1% for serious complications, and the success rate is excellent. Over 90% of patients experience significant or complete relief of their symptoms. If your nerve conduction studies show moderate to severe compression, surgery is usually the most reliable path to preserving your hand function long-term. Finally, I want to emphasize the importance of addressing the underlying conditions that contribute to carpal tunnel syndrome. If you have diabetes, optimizing your blood sugar control reduces nerve vulnerability. If you have hypothyroidism, ensuring your thyroid hormone levels are adequately replaced reduces tissue swelling. If you are carrying excess weight, even modest weight loss, 5 to 10% of body weight, can reduce pressure in the carpal tunnel. If you have inflammatory arthritis, working with your rheumatologist to control inflammation protects the tendons and reduces swelling inside the tunnel. Treating carpal tunnel syndrome is most effective when you address both the local nerve compression and the systemic conditions that contributed to it. Let me add one more important consideration that affects a large number of seniors: the relationship between carpal tunnel syndrome and sleep quality. Chronic nighttime tingling and numbness do not just damage your nerve, they damage your sleep. Waking up multiple times per night to shake out numb hands disrupts your sleep architecture, reducing the amount of deep sleep and REM sleep you get. Poor sleep quality has cascading effects on every aspect of your health. It raises blood pressure, impairs immune function, worsens pain sensitivity, increases inflammation, impairs memory and cognitive function, and raises the risk of falls and accidents during the day. So treating carpal tunnel syndrome is not just about protecting your hand. It is about protecting your sleep, which is about protecting your entire body. I also want to mention that carpal tunnel syndrome is not the only condition that can cause hand symptoms at night, and distinguishing between them matters for treatment. Cervical spondylosis, arthritis of the neck, can compress nerve roots that travel down the arm into the hand, causing numbness and tingling that may be worse at night when you lie in certain positions. The key difference is that cervical nerve compression typically affects all 5 fingers, not just the thumb through ring finger, and may be accompanied by neck pain or stiffness. Peripheral neuropathy from diabetes typically causes a symmetric stocking and glove pattern affecting both hands and both feet, often with burning pain rather than pure tingling. And Raynaud's phenomenon causes color changes in the fingers, white, then blue, then red, in response to cold, which is a distinct pattern from nerve compression. If your symptoms do not fit the classic carpal tunnel pattern, mention this to your doctor so they can investigate alternative diagnoses.